Welcome to Stago Educational Shorts. Short lectures covering the essentials of key coagulation topics. Presented by world-renowned experts. And designed to fit around your busy schedule.
So I'd like to thank Stago for inviting me to speak on my favourite topic, von Willebrand disease. This is actually a second part to another part that's available. So this slide shows you the most common test panel for investigation of von Willebrand disease. So most laboratories use 3 tests as a test panel. They perform a factor VIII activity assay, usually by a one-stage assay of coagulant activity, factor VIII-C, and usually an automated analyzer. Less commonly, some laboratories also use a chromogenic assay, but this is usually only available in haemophilia centres. The other assay that most laboratories use is a VWF antigen assay, which measures the level of von Willebrand factor protein. This assay measures both functional and non-functional VWF. Typically performed by turbidimetric methods, latex immunoassays or equivalents, usually on automated analyzers. Used to be performed by ELISA, but ELISA is now rarely performed, and occasionally performed using other techniques, for example, a clear methodology, which I'll talk about as well. The other main assay that most laboratories use is a VWF activity using a glycoprotein 1b binding assay. So these assays are designed to be sensitive to specific von Willebrand factor defects or von Willebrand factor conformational changes that occur in patients with 2A, 2B or 2M von Willebrand disease. It's also designed to be sensitive to high molecular weight VWF. Now these assays, as I mentioned briefly, is a risk-seeking cofactor assay and also the glycoprotein 1br and glycoprotein 1bm assays. So classically, risk-seeking cofactor is a historical method that most laboratories used. They currently perform as an agglutination assay on an automated analyzers in most laboratories now, but in the past used to be performed using an aggregometer. I also want to mention that in terms of laboratory diagnosis, it's very important to include a collagen binding assay. So this is an assay which measures an additional activity of von Willebrand factor, that is collagen binding. And as I mentioned briefly, in vivo, collagen binding to von Willebrand factor is an important way of von Willebrand factor actually attaching the platelets to the site of injury. So in other words, von Willebrand factor has binding sites for both glycoprotein 1b on platelets and also collagen, which is a subendothelial matrix protein which is exposed upon injury, and that von Willebrand factor can then bridge between the injury site through binding to collagen and the platelets through binding to glycoprotein 1b, and then immobilize platelets to the site of injury. And we can design assays that are sensitive to functional activity of von Willebrand factor. So ELISA assays can be designed to be sensitive to specific von Willebrand factor defects, for example, conformational changes that occur in 2A, 2B, and 2M, and also designed to be sensitive to high molecular weight von Willebrand factor, and thus be able to identify a loss of high molecular weight VWF. ELISA assays require assay optimization, and not all ELISA assays are actually fit for purpose. So type 3 collagen binds to von Willebrand factor too avidly and then leads to a poor discrimination of high molecular weight VWF if it is used at high concentration to coat wells. Type 1 collagen binds von Willebrand factor too poorly and actually then leads to poor anchoring of von Willebrand factor in the ELISA assay and is also not recommended. And what studies from our laboratories indicated is that it's actually a mixture of either type 1, type 3 collagen or perhaps type 3 collagen used at a lower concentration that seems optimal to provide optimal discrimination of high molecular weight VWF. But there are also newer clear assays which can also be utilized. This is a slide which just shows you some of the assays that's available from Stago. So Stago has a factor VIII activity assay, a one-stage activity assay of coagulant activity performed on automated Stago analyzers. It has assays for von Willebrand factor as a measure of von Willebrand factor protein, either by ELISA or by a latex immunoassay. The latex immunoassay is also obviously automated. The ELISA can be automated on an ELISA instrument. Von Willebrand factor activity by a glycoprotein 1b binding assay, specifically a ristocetin cofactor assay that can be formed as an automated process on a Stago analyzer. Stago also has a collagen binding assay, and we've actually performed an evaluation of this assay, which we published, and the reference is there, and I'm happy to provide a copy of that reference if you send me an email. And lastly, Stago also has a von Willebrand factor VIII binding assay that's available, and indeed I believe it's the only commercially available factor VIII binding assay. Then there's a methodology that we call multimer analysis. This is also an adjunct, if you like, to the diagnosis of von Willebrand disease. In multimer analysis, what we're looking for is a loss or the presence of the high molecular weight von Willebrand factors. So in this slide, I'm showing you some examples from an evaluation of a new semi-automated method that we've evaluated at Westmead. This is a methodology that where results can be obtained in one day and approximately 4 hours of hands-on time. There are gels that come in either 5-lane gel format or an 11-lane gel format. This slide shows you results from a 5-lane gel format. So in this slide, we can see that the first lane shows normal plasma. The second lane shows some example of where you have a loss of high molecular weight von Willebrand factor that you will see in type 2A or 2B von Willebrand's disease. In this case, it's a 2A. The third and fifth lanes here, you have all the von Willebrand factor multimers, including the high molecular weight VWF, and you'll see this pattern either in normal individuals, in type 1 von Willebrand disease individuals, or in these examples as type 2M von Willebrand disease. And this is one of the means that we can separate out type 2A from 2M von Willebrand disease. And the fourth lane here is just showing an example of a type 2B von Willebrand disease, which is also having a loss of high molecular weight VWF. So it's important to identify also type 2N von Willebrand disease. Type 2N von Willebrand disease is where you see a loss of factor VIII binding to von Willebrand factor that gives you a loss of factor VIII activity in plasma. And these patients actually phenotypically look a little bit like patients with hemophilia A. And the only way to distinguish patients with hemophilia A and type 2N von Willebrand disease is either to perform a factor VIII binding assay or to undertake genetic analysis. And as I indicated, the Stago acerochrome factor VIII binding assay is the only commercially available factor VIII binding assay that I'm aware of. Otherwise, you need to use an in-house factor VIII binding assay. And here I'm just showing some references where we've undertaken assessment of patients with 2N von Willebrand disease in our laboratory. And I'm happy to share any of those references if you ask me. In this next slide, I'm just showing you quickly where genetic analysis may be of use in the diagnosis of von Willebrand disease. And essentially, this is in type 2 von Willebrand disease. So wherever you have a provisional diagnosis of type 2, be it 2A, 2B, 2N, or 2M, then we would recommend genetic analysis. Also recommend genetic analysis in type 3 von Willebrand disease and also in platelet type von Willebrand disease, which I didn't talk about because it's not really a von Willebrand disease, but it's a phenocopy, if you like, of a 2B von Willebrand disease where you have a mutation not in the von Willebrand factor but in the glycoprotein 1b molecule on platelets, which causes a hyperadhesive platelet that binds spontaneously to von Willebrand factor. So platelet type von Willebrand disease presents phenotypically very similar to 2B von Willebrand disease, and there are ways of distinguishing those. And in this last slide, so this last slide is just showing you a summary of how one could diagnose Willebrand disease by using the assays that I've briefly mentioned. So in type 1 von Willebrand disease, you expect to see a low level of von Willebrand factor, but all the von Willebrand factor assays provide with similar results. So if you take a ratio of any assay over another, and we usually take a ratio of activity assay to the antigen, then that ratio will be greater than 0.7. And you can replace risk-seeking cofactor with any of the modern alternatives, such as glycoprotein 1Br or glycoprotein 1Bm. In type 3 von Willebrand disease, we have undetectable von Willebrand factor, but we have to recognize that there are lower limit of detection issues. But if we have a von Willebrand factor level less than 5% or units per deciliter, in particular, I'm talking here about von Willebrand factor antigen, then we can effectively diagnose von Willebrand disease type 3. And we expect the collagen binding and risk-seeking cofactor to also be very low and typically less than 5 units per deciliter. In type 2A, we expect to see a loss of high molecular weight VWF. So here what we will see is a low level of von Willebrand factor antigen, but importantly a disproportionately lower functional von Willebrand factor level. So collagen binding and risk-seeking cofactor, or its modern alternatives, will be disproportionately lower than von Willebrand factor antigen. So if you take a ratio of a functional activity to antigen, be it risk-seeking cofactor to antigen, collagen binding to antigen, or the modern glycoprotein 1Br or glycoprotein 1Bm to antigen, then we expect all those ratios to be under 0.7. In 2B, von Willebrand disease, the actual diagnosis is achieved using a low-dose ristocetin-induced platelet agglutination assay or genetic testing, but we also expect to see, like in 2A, loss of high molecular weight VWF, so thus disproportionately lower von Willebrand factor collagen binding and risk-seeking cofactor or its modern alternatives than von Willebrand factor antigen. So again, the ratios will be less than 0.7. In 2N, we diagnose these patients using the factor VIII binding assay or genetic analysis, where we expect the level of factor VIII bound in the assay that we perform to antigen, von Willebrand factor antigen, to be less than 0.7. But initially, in a screening process, we expect to see a lower level of factor VIII-C to von Willebrand factor antigen. Again, that level would effectively be less than 0.7, but that's also seen in hemophilia A. So we need to distinguish 2N von Willebrand disease from hemophilia A using a von Willebrand factor VIII binding assay or genetic analysis. And then in type 2M von Willebrand disease, what we expect to see is a low level of VWF activity, lower than the antigen. So again, the ratios will tend to be low. But here we may see both the glycoprotein 1B binding to antigen ratios being low, plus the collagen binding to antigen being low, or maybe we might see only one of those ratios being low. So in particular, if we only see one of those ratios being low, so either glycoprotein 1B binding to antigen or collagen binding to antigen, then that by definition infers a 2M von Willebrand disease. But if we see both of them being low, then that could be a 2M or could be a 2A or 2B von Willebrand disease. Von Willebrand disease is the most common bleeding disorder. It's actually more common than hemophilia A. Hemophilia A occurs in about 1 in 5,000 individuals, primarily male. Von Willebrand disease, the incidence of von Willebrand disease depends on how you measure it. If you perform epidemiological studies, then you can infer that von Willebrand disease is present in up to 1% of the population. If you also assess all the population, then you will identify a low level of von Willebrand factor in up to 2% of the population simply because of the way that normal ranges are defined. So up to 2% of the population will have a level of von Willebrand factor that's less than the normal range simply because of the way that normal ranges are defined. In terms of patients presenting to doctors through bleeding that are then eventually diagnosed with von Willebrand disease, it's probably about 1 in 10,000. So it's misdiagnosed sometimes in some patients with von Willebrand disease. It's misdiagnosed as not, these patients may be misdiagnosed as not having von Willebrand disease. In some patients with von Willebrand disease, it's misdiagnosed as another form of von Willebrand disease. For example, a patient with 2B Willebrand disease can be misdiagnosed as having a 2A Willebrand disease. A patient with type 3 Willebrand disease can be misdiagnosed as having haemophilia A, if only the factor VIII is performed and not von Willebrand factor. So it's commonly misdiagnosed. It can be underdiagnosed because the tests for von Willebrand factor are either not performed and only factor VIII testing is performed, or the laboratories use the wrong panels, and therefore they miss certain von Willebrand factor mutations or von Willebrand disease patients. And sometimes it's sometimes it can be overdiagnosed as well. In particular, type 1 von Willebrand disease can be overdiagnosed, as I said, because 2% of the population can have low levels of von Willebrand factor, and indeed, patients with O group blood tend to be overdiagnosed as having type 1 von Willebrand disease. Primarily, the most common would be those related to processing. So in other words, samples have been collected and then have not been processed appropriately. So either they've been refrigerated for a period of time, or they've been centrifuged and separated, but they've been frozen and then not thawed properly before aliquoting. If you refrigerate whole blood samples, then you can get a false type 2 pattern. If you have a sample that's been frozen and not properly mixed after thawing, then again you can get a type 2 pattern. But also the pre-analytical issue I mentioned in terms of the clinical ordering is also important, not only for von Willebrand disease but also for haemophilia. For example, if a doctor only orders a factor VIII, then that patient with von Willebrand disease, for example type 3, will be missed. Similarly, if your doctor only orders factor VIII and haemophilia, then that patient may have type haemophilia B with factor IX deficiency, and that patient may also be missed. So it's also important for clinicians to order the right tests. Thanks again to Stago for inviting me to present on von Willebrand disease. It's my favourite topic, and I thank the audience for listening to my presentation, and I hope to see you in another session at a later time.
Thank you for watching the Stago Educational Short. You can find other presentations by world-renowned experts on similar topics at www.stagowebinars.com. To learn more about the field of hemostasis and thrombosis, download iHemostasis from the App Store or Google Play Store onto your tablet. iHemostasis is a global education tool dedicated to the pathophysiology of blood coagulation, illustrated by clinical cases, designed for everyone from clinical professionals to students. You can also sign up to our newsletter to keep up to date with the latest scientific topics, educational materials, and giveaways at stago-uk.com. For answers to the most important coagulation questions, listen to our Ask Stago podcast, available on all popular streaming services. You can also submit your questions by email at ask@stago.com.